Hello, everyone. My name is Justin Banerdt. I'm an internal medicine resident physician at Yale, and I'm grateful to be able to talk with you during World Delirium Awareness Day about delirium as an issue of global health importance in low-income countries. Specifically, I'll be talking about the findings from our study on delirium prevalence and outcomes from Zambia. Delirium is a form of acute neurologic injury that is common among critically ill patients. Studies in the US and Europe have shown that it occurs in anywhere from 20 to 80% of ICU patients. Its importance has been established over the last 2 decades, where studies have shown that delirium is an independent predictor of long-term mortality, as well as long-term cognitive impairment. And this has led to recognition of delirium as an issue of major public health importance, with healthcare costs attributable to delirium ranging from $143 billion to $152 billion in the US alone, and as well as untold disability and mortality from delirium. The Society of Critical Care Medicine's ICU Liberation Initiative, as well as other initiatives, have aimed to liberate patients from the harmful effects of delirium in the ICU. Unfortunately, we know very little about delirium in Africa. A recent review of the literature on delirium in Africa showed significant methodological concerns in most studies, and most studies didn't use validated instruments for delirium assessment. Furthermore, little is known about the long-term outcomes of critical illness, including delirium, in resource-limited settings, though the global burden of critical illness is disproportionately high in low and middle-income countries, or LMICs. This graph shows the significant disparity in the global burden of critical illness between high and low-income countries. You can see that low-income countries have a significantly higher percentage of deaths as well as total deaths from conditions that would potentially benefit from the availability of critical care. So the aim of our study was to assess the epidemiology and outcomes of delirium in a population of hospitalized patients in a resource-limited setting at high risk of death. And our primary hypothesis was that duration of delirium in low and middle income country patients would be an independent predictor of 6-month mortality and disability. We received multilateral IRB approval for this study. The setting of the study was Zambia, which is a country with approximately 18 million people with a high HIV prevalence of around 11.3%. We conducted our study at the University Teaching Hospital, which is a 1,600-bed national referral hospital in the country's capital, Lusaka. And this hospital has about 17,000 acute admissions annually, of which 45% would meet criteria for critical care triage. However, there's only 10 total ICU beds available in the entire hospital. And this speaks to the substantial burden of critical illness in healthcare settings in Zambia, but the significant lack of critical care capacity in the country. There are only 91 reported adult ICU beds for a country of 18 million people. And this situation led to our realization that in this setting, really the hospital is an ICU without walls, that the vast majority of critically ill patients are taken care of outside the walls of the ICU and the general medical and surgical wards, which is what led us to conduct our study among the general medical and surgical ward patients. We conducted a prospective cohort study in which we assessed patients for delirium during the first 3 days of their hospitalization, and then we followed them for 6 months to assess outcomes. Our inclusion criteria for this study included patients aged 18 years or older who were admitted to the medical and surgical wards. We also conducted a 7-day point prevalence study to assess delirium point prevalence in this population. The primary exposure was delirium, delirium duration specifically over the first 3 days of hospitalization. We assessed patients on day 1, day 2, and day 3, or on a daily basis over 3 days for delirium. We used the brief confusion assessment method, the BCAM, for delirium assessment. The BCAM is a validated tool for assessing delirium in non-ICU settings, and we followed standard guidelines to create translated versions of this instrument for the local languages. Our primary outcome was 6-month mortality, and our secondary outcomes included 6-month disability as well as 28-day mortality. For our 6-month disability outcome, we used the WHO Disability Assessment Schedule 2.0, which is a comprehensive evaluation of disability status across 6 functional domains, including cognition, mobility, self-care, getting along with people, life activities, and participation. And this instrument has been validated cross-culturally for use in LMICs. We perform regression modeling for these outcomes. All regression models were adjusted for 7 a priori defined covariates, including age, sex, education, income, severity of illness assessed using the UVA score, which is a validated severity of illness score for use in sub-Saharan African populations, as well as HIV status and TB treatment. The results of our study, so we included 711 patients for analysis. 345 had delirium, with 191 alive at 6 months and 154 who passed away at 6 months. In terms of baseline characteristics of this patient population, you can see that delirious patients they were relatively young, median age of 45, 63% were male, 69% were medical admissions versus 31% surgical. 54% of these patients earned less than $50 per month. So this was an extremely poor patient population. The median severity of illness measured by UVA was 6, suggesting that this was a patient population with a high burden of critical illness and high risk of death. 46% of delirious patients were HIV positive in this cohort, and 27% had a history of TB infection. Delirium prevalence at enrollment was 47% in the primary cohort versus 43% in the 7-day point prevalence study. And there were 49% of HIV positive patients were delirious versus 46% of non-HIV patients. You can see here that by 28-day mortality, the 27% of delirious patients had died at 28 days versus only 12% of non-delirious patients. And 45% of delirious patients were dead at 6 months versus only 20% of non-delirious patients. Looking at Kaplan-Meier survival curve for 28-day survival, we can see here that patients who had any exposure to delirium, indicated by the dotted red line, had significantly lower probability of survival at 28 days. And this is our multivariable regression analysis of delirium duration and clinical outcomes, adjusting for 7 prospectively defined covariates that I mentioned before. You can see here that there is a clear dose response association between delirium duration and worse clinical outcomes. Looking at 28-day mortality, you can see that 1 day versus 0 days of delirium and 3 days versus 0 days resulted in nearly 3.4 increased odds of mortality. For 6-month mortality, you can see for 2 days of delirium, there was essentially 2-fold increased risk of 6-month mortality. For 3 days of delirium versus 0 days of delirium, there was a nearly 4-fold increased risk of 6-month mortality. And you can see a similar trend here for 6-month disability as well. This is a forest plot of our multivariable regression analysis where you can visually see the dose response association with increased days of delirium exposure resulting in a higher odds of 28-day mortality, 6-month mortality, and 6-month disability, such that patients with 3 days of delirium had a nearly 4-fold increased risk of 6-month mortality and nearly 3-fold increased risk of 6-month disability. So this prospective cohort study found that delirium was significantly and independently associated with higher mortality and greater disability at 6 months among hospitalized patients in a resource-limited setting with a large burden of HIV, TB, and critical illness. Nearly 50% of patients in this patient population had delirium, and delirious patients had a 44.6% 6-month mortality rate, which was more than double that of patients without delirium. Even more striking, there was a significant dose-response relationship between the duration of delirium exposure and odds of worse clinical outcomes, even after controlling for covariates. And to our knowledge, this is the first prospective cohort study of hospitalized adult patients in a lower middle income country to assess the relationship between delirium and 6-month mortality and functional outcomes. Our 98% follow-up rate using cell phones demonstrates that long-term follow-up of clinical outcomes is feasible in resource-limited settings among patients who experience the significant burden of delirium and high mortality. And this has important implications for the field of global critical care and the design of future studies, as prior studies in low-income countries have not been able to achieve long-term follow-up for critically ill patients. Furthermore, this speaks to the fact that delirium is a public health crisis impacting patients in lower middle-income countries. These findings suggest that the substantial burden of delirium and associated morbidity and mortality in resource-limited settings constitute a significant public health crisis affecting socioeconomically and medically vulnerable patient populations in these countries. Delirium should be considered, therefore, a global health issue of central importance affecting the lives of the critically ill poor around the world. Further studies are therefore urgently needed to assess whether detection, prevention, and management of delirium in resource-limited settings can improve patient outcomes. Now, in terms of the COVID-19 pandemic, delirium is increasingly being recognized as an epidemic within the COVID pandemic, with significant percentages of hospitalized patients with COVID developing delirium. The COVID-19 pandemic will likely only exacerbate the already significant burden of delirium in resource-limited settings, and this should be a call to action to prevent, identify, and mitigate the substantial morbidity and mortality associated with delirium in low and middle-income countries. The COVID-19 pandemic provides, therefore, an opportunity to accelerate and scale up global efforts to raise awareness of and address delirium in critically ill patients, particularly in resource-limited settings where the burden is substantial. So in conclusion, delirium prevalence was high among hospitalized patients in this Zambian cohort, and delirium duration was a strong independent predictor of 6-month mortality and disability. There is a driving unmet need to understand better the epidemiology and outcomes of delirium as a prognostically important form of acute organ dysfunction in resource-limited settings. Furthermore, these data speak to the fact that delirium is important in predicting outcomes for hospitalized patients in sub-Saharan Africa, a point which was previously not known. And these findings are a call to action to focus on prevention, detection, and management of delirium in LMICs, particularly during the COVID-19 pandemic. I'd like to acknowledge my mentorship team, which included Wes Ely, Doug Heimberger, Kondolani Mateo, Elizabeth Riviello, and Deanna Saylor, as well as the extraordinary efforts of my research team at UTH, including Jainaba Vlahakis, Adraida Tembo, Leticia Mukomena, and Martin Simonyama, as well as the biostatistics support from Lee Wang and Christopher Linzel. I'm also grateful for funding from the Fogarty International Center and for support from the VECD, Vanderbilt Emory Cornell Duke Fogarty Global Health Fellowship, of which I was a participant, as well as the Vanderbilt Institute for Clinical and Translational Research. Our study was just recently published last month in PLOS One. It's entitled Delirium as a Predictor of Mortality and Disability Among Hospitalized Patients in Zambia. And I would encourage you to read the study if you would like to find out further details about our results. Thank you so much for listening. And I'd be happy to answer any questions or comments. Please feel free to email me. Thank you again.